I believe that Dr. Brawley is joining us virtually. I believe he's here, and you probably have his slides up there already. Welcome,
Hello.
Aziz. Good morning.
Hello. Hello. Thank you for having me. I'm very sorry I can't be there. Now, should I be sharing my slides, or are my slides being projected?
Go ahead and share the screen, please.
Okay. And do you see them now?
We do. Go ahead.
Great. Thank you. It's a true honor to be asked to give this talk. It made me think about a lot of really important things. And I also want to thank the staff at the National Academy, and I especially want to thank Laurie Brennick, who is perhaps the most patient person in Washington, D.C. These are some of my disclosures, or these are all of my disclosures. I'm going to talk a little about the cost of healthcare in the United States, define health disparities, broadly define health equity, and then talk about the interaction between the two, and then make a few observations about medicine. I'm going to start out by giving you the punchline. Whenever we introduce a new technology into medicine, we actually create disparities. There's a group of people who get it and a group of people who do not get it. And that's something to be very, very important. And the other point here, which is I'm giving my summary now for folks who want to fall asleep, we need to do studies looking at the distribution of various markers across populations. Okay, now the cost of American healthcare. In 2019, the last year of normal time before COVID, healthcare in the United States cost $3.8 trillion, or 17.7% of every dollar spent in the United States. 17.7% of our economy. Let's compare that to other countries. Germany comes in as number 2 at almost 12%. But these are what other economies are spending on healthcare. And I want to keep in mind the fact that every country has disparities, but the disparities in the United States tend to be worse, especially when we look at mortality. Now, when we talk about disparities, it's a difference. And it can be incidence, it can be mortality, survival, quality of life. I tend to follow mortality more so than any other. When we talk about populations, we can talk about sex or gender. Race is frequently discussed, area of geographic origin, which can be similar to race, family or tribe, ethnicity, area of residence, and socioeconomic status. I want to point out that the Office of Management and Budget defines race every 10 years in the United States. It is a socio-political categorization, and race does change. For example, if you know someone from India, they were white in the 1960 census, and they've been Asian in other censuses, an Asian Pacific Islander in others. President Obama was considered white in 1970 and black in 1980. So we have to be careful when we look at race, although race is important in telling us that certain populations, especially blacks, are less than likely to get optimal care, but a substantial number of Americans, especially poor Americans, even poor whites, are likely to get less than optimal care, and that can be less than appropriate screening, diagnostics, treatment, and so forth. And when we're talking about introducing these new technologies, these people are more likely to get it last. Now, when candidates, let me give you some example. We have data to show that Black Americans and poor Americans who need radiation therapy are more likely to be radiated by older, lower energy, lower quality radiation therapy machines compared to middle and upper middle class Americans. There is literally a difference in the quality of the machine in radiation therapy. Again, whenever there's a new intervention, we have a disparity. I want to show you, this is just looking at women with colorectal cancer. We can show you the same thing looking at men with colorectal cancer. Breast cancer, there was an issue with cervical cancer screening in the 1960s. There was an issue. You see, there was no black-white disparity for colorectal cancer mortality in the 1970s. The death rate was 25 per 100,000 per year for black women as well as for white women. It was in the 1970s that screening and treatment for colorectal cancer got better, and then with some lead time, by about 1980, we started having disparities in mortality for colorectal cancer between blacks and whites. I don't have time to discuss what happened with Native Americans, Hispanics, and Asian Pacific Islanders. We only started publishing data on them in 1990 due to an executive order from President Reagan in the middle 80s. But please notice the disparity between blacks and whites once we learn how to screen and treat for the disease. And again, you can see this in breast cancer. You can see it in a number of diseases. You can go outside of cancer. You can see it in cardiovascular disease with coronary artery bypass. Now, when we talk about disparities, there's even disparities in how pathology is assessed. Blacks are more likely to be treated in hospitals where the pathologist has multiple cases. And so in colorectal cancer, there are a number of papers now about how blacks with colorectal cancer on average, or you can say poor people with colorectal cancer on average, have less numbers of lymph nodes assessed compared to upper middle class and middle class. Indeed, some of the shibboleth about colorectal cancer being more aggressive in blacks versus whites is based on most people who are stage 2 and black with colorectal cancer have had 6 lymph nodes assessed. Most people who are stage 2 and white have had 18 lymph nodes assessed. And as you know, stage 2 blacks tend to do worse than stage 2 whites because they haven't been adequately staged. Again, how we can provide adequate high quality care to populations that so often don't receive it is incredibly important. Many Americans get their care in resource poor settings, and unnecessary care consumes limited resources and interferes with abilities to provide necessary care. What I'm trying to say here is, as we develop these new technologies and we start talking about bringing these new technologies into these resource-poor settings, and it's not just county hospitals I'm talking about. There are many suburban community hospitals that are resource-poor. We can actually create a worsening of healthcare and increased disparities. For example, the easiest example is I used to be director of a cancer center in Atlanta, a community safety net hospital. If we try to do lung cancer screening there, we make the line for the CT scanners longer for everybody, and we worsen overall quality of care for everybody. Now, the National Academies have said high quality healthcare is doing the right thing at the right time in the right way for the right person and having the best possible results. This is simple equity. Some populations are going to need more help to get where we all want to get versus other populations. And this leads us to a brief discussion of implementation science, which is the new buzzword out there. It's the study of methods and strategies to promote uptake. And there is differences in implementation. This is a simple look at the implementation taxotere for prostate cancer. This is just to show that we have data to show that older people got it slower than younger people, whites got it faster than blacks, and the poor got it slower than the wealthy. We also have data to show that Black women are less likely to get genetic testing for breast cancer. We have a number of studies out there looking at genomics, and they tend to have large European populations. And this is actually another very important point of the talk. What we need to, there's a lot of stress on looking at subset analysis of differences between blacks and whites and so forth in these large treatment trials. What we need are some large studies of genomics that actually just look at the distribution of various genomic markers. This is just, again, to show you there's this problem has created the situation where a number of blacks who get these genetic studies now in practice end up with variants of unknown significance compared to non-Hispanic whites. And you can see it's a problem for Asians as well. The opportunities, as I sum up, implementation and diffusion, de-implementation, de-escalation, and savings of resources. What I mean by that is the reduction or elimination of inappropriate, ineffective, and even harmful care may come by these new technologies being introduced and being introduced well. We may stop giving people treatment that doesn't work. By the way, for example, tamoxifen was introduced in the early 1980s before the estrogen receptor test. The introduction of the estrogen receptor test meant that we could stop giving tamoxifen to women in whom it wasn't going to work. Some common interventions do need to be de-escalated and de-implemented or retired. This may help us as we develop these marker studies. Again, there's been this emphasis on large clinical trials. We really need to, as we move into the world of precision medicine, we need to study interventions and markers and study the distribution of those markers among the populations and populations other than race, I should say. Look especially at area of geographic origin. Last slide, we need to use evidence-based care and prevention. We need to be rational in our practice of medicine, realize we're frequently irrational, and we need to not ration medicine, which is already happening. And so I'll stop at that point. Thank you. Trying to stay under the time limit.